Thank you for joining us today. First, I'd like to say thank you to all the healthcare workers and frontline workers who are in all the hot spots across the United States and across the globe. We have just a few housekeeping details to share before we get started. This program is being recorded, and the link for the video will be available within a few days. The recording will be shared by email and will be posted on our website, and continuing education credits will also be available. When today's webinar concludes, participants may click on the evaluation link in the description below this video window to obtain continuing education credits. I'm joined today by two leaders from Brigham and Women's Faulkner Hospital, and we are very delighted that they have agreed to take the time out of their very busy schedules to help us understand some of the leadership issues involved in this pandemic. Corey Loescher is the Chief Nursing Officer and Vice President of Patient Care Services at Brigham and Women's Faulkner Hospital. She's been at the Faulkner for 21 years in varying nursing leadership roles and has been the Chief Nursing Officer for the past 3 years. Corey has led the organization through the Magnet Journey, achieving Magnet designation in 2019. She has been actively involved in the ongoing development of integrated care teams that support partnerships across the organization to improve patient outcome, to support staff, and to develop leaders. She is responsible for emergency preparedness for the organization, the executive sponsor to the BWFH Emergency Management Committee. Corey received her nursing education at St. Anselm College and has had nursing leadership roles in the AMC as well as community hospital settings. We're also joined by Peggy Duggan. Peggy is the Chief Medical Officer and Vice President of Medical Affairs at Brigham and Women's Faulkner Hospital. Peggy has served in this role since June of 2013. Prior to that, she served as Medical Director of the Brigham and Women's Faulkner Breast Center for many years and held numerous committee leadership positions. Most recently, she's taken on the task of Medical Director of Credentialing for the Mass General Brigham System. Peggy is a tireless advocate for patient safety and a strong voice supporting the needs of the medical staff. She trained in surgery at Boston Medical Center and remains clinically active in breast surgery. So I work very closely with these two amazing women, and I was delighted that when I asked them to join us for this webinar series, that they very quickly agreed. And so I want to take us first on sort of a history tour of the pandemic and ask each of you when you first heard about COVID-19, when it first appeared on your radar screen, and when you start really thinking about it as a potential problem for the institutions. Corey, why don't you start?
So back in December, I think many of us were hearing about coronavirus in China. And that this was a novel virus that we weren't quite sure what was going on, and it was escalating exponentially. And we at the MGB level, Mass General Brigham, actually were already involved in a China-oriented event related to the cardinal gowns. And the fact you probably all heard that there was concerns about sterility, about surgical gowns. So we had already stood up a whole structure around managing that response that we couldn't do surgery. And literally, we were meeting weekly on that. And in the middle of January, Incident Command was urgently and emergently turned. Our local emergency management committee had started with our small group to say, hey, there's something going on, an emerging infectious disease, and we need to respond to it and plan what we're going to do. And literally within the space of less than 10 days, we stood up an entire incident command at the end of January to start to deal with this event.
Peggy, what about you? When did COVID first appear on your radar screen?
So interestingly, as my leadership position at Mass General Brigham and credentialing had just started at the same time as the cardinal gown issue as well. So Corey and I were both engaged in that work, but I was asked by our chief clinical officer at Mass General Brigham to sit on the EOC committee for the cardinal gown work, since they were looking for a surgeon to give input. And about the end of December, Paul Bittinger, our leader across the system for emergency preparedness, started saying in those meetings, I just want to take a minute to warn you all about this virus in China that I'm hearing about. And then, as Corey described, within about a week, she and I were standing in the antechamber of her office, and she was saying, I think we have to open the full incident command for this. And so it was incredible how rapidly it went from a virus in China to a worry for us to full operations every day. And I think about this in a way as to how closely the two of us work as we were hearing it different channels at the same time and coming to the same conclusion, really, that it was time to really start activating our troops around this.
So that I understand how things work across the health system. So you said that Corey said that we need to open an incident command system. Was this happening at different times across the organization? Were all the hospitals within MGB setting up the incident command at the same time?
So incident command.
So there is an overarching. Oh, sorry, Corey. Go ahead. Yeah.
Go ahead. Go ahead,
Corey.
So there was
I was
already.
Going to say the Mass General Brigham had opened that.
All right, Corey,
not
go ahead.
talk over each other.
Corey,
Yes,
go ahead.
you.
You go first.
We need help.
So there was already an overarching incident command structure set up for the Cardinal Guard recall. And to understand, we had a local chapter of that. So you usually start locally with an incident command, and depending on the event, it escalates. But because Brigham and Women's Faulkner is part of the Mass General Brigham system, we had already been activated, and that was novel across all of our entities. Never before had we ever gone all the way across all of the institutions at all levels to start to respond to something. And there was power in being part of MGB on securing resources, but there needs to be local leadership and local understanding and a local response team. And that's where Peggy and I were integral in not only participating at the highest level across MGB, but also representing the local responses and what we had to do.
Great. So, Corey, I'll ask you first. In your career, had you ever been involved in any kind of pandemic response like this one?
No, not ever. I think we've responded to something of smaller. We prepared for Ebola a number of years before, and that had a similar kind of preparation of an unknown emerging infectious disease. That was probably the biggest event that we needed to look at, but nothing to this magnitude by a long shot.
What about you, Peggy?
So I agree. We had, I'm not sure any of us have been involved in something of this magnitude across the globe. And so the part of this disease that makes it so compelling is its infectious ability, right? And so it's hard for any part of the globe not to be engaged in this. I have never been involved in work where we stopped everything we were doing in order to prepare. Usually we were doing our normal daily work and then planning in parallel for another event or an in-case event, right? Maybe this will happen and we want to be prepared. I've never been through anything where we have literally stopped on a dime and turned our attention to one project, or where we've turned the hospital into a treatment center for one disease. It is really unique and different, and we did that across our system. It is really a unique experience that I'm not sure any of us could claim to have been through before or have had good practice for in any way. Yeah.
So I'd like to turn now to talking specifically about the incident command structure, and I'll ask Eddie if he could bring up the slides that you all were so kind to prepare for us. And Corey, if you will walk us through, you can ask Eddie to advance the slides as you see fit.
Sure. So Eddie, you can go to the next slide to give a little understanding. The HICS system, it's a standardized model that you use across all disasters, and it covers all responding entities, and it's got common language and common structures that allow you to respond, but also to divide work into reasonable structures. And this incident command, HICS, Hospital Incident Command System, was what we started with, which seems pretty small and pretty localized. And that was our initial, back in when we first got there's this disease coming forward, and said, all right, we will be fine, we can handle this. And if you go to the next slide, and we started looking at some of our responses. This is a respiratory illness. We need to make sure all the staff are tested on wearing PPE and training people. We need to get carts out and make sure we have inventory. We need to know where we're going to put some of these patients and start screening patients at the entrance. It was very small, believing it was very contained, and we potentially would not be seeing this many patients. And then you go to the next slide, and within a week's period of time, you're starting to see a command structure now with much more expansive breadth and depth and redundancies. And we'll just scroll through slides so our audience can see the actual depth of process institutions. So keep going, Eddie. That each one of those branches now have an enormous infrastructure below us that now has redundancies. So you're looking at running the operations completely. So there's an operations branch. You move into the next branch, the next slide, where you have a planning branch. So what if we need to build a brand new ICU that we never had before? How are we going to manage closing and redeploying staff? What is the response we're going to do for looking to try to do staff that get sick, and how are we going to manage sick staff? The other next branch on the next slide is the logistics branch. So where are all of our supplies coming from? Will we have enough of them? Do we have resources to move patients? Do we have an ability to care for staff? Where are people going to sleep if they have to stay in the institution? So we have that level, and then the last slide is the branch around financial. And literally, that was the last of our components. It was collecting how much is this costing us and trying to recapture, but it is astronomical when you started to look. And not only was this structure here, but each of the other hospitals across MGB had a similar structure, and then there was an overarching structure exactly like this for all of MGB, planning for us as an enormous healthcare system. And Peggy, you were certainly part of that at the highest level. Do you want to speak to the MGB level of this work?
Yeah, so every day, and maybe it's the cadence of meetings that is most like compelling or descriptive, but every day at 7 a.m. was the beginning meeting at the partners level for the incident command. And then as you came back to your entity, we would have a meeting shared with the Brigham, as we are very aligned and attached to the Brigham, where we would sit and be a part of their incident command meeting. Then Corey would lead our local incident command meeting, so we could bring the information from both of those meetings, plus data from our daily census. Did we have enough supplies for today, for tomorrow, for the next day? Those were the types of questions we were asking in each setting. And then as we rolled through the day, were people having, we would have, do you have enough food for the staff today? Are we bringing food in to make it easier for people? What are the types of things we're doing to make this a little bit of an easier time? Who's communicating? Are we making rounds, walking around, checking on our staff? And then I had since I was also in the operational section, I would end my day with the operations meeting and hear how things went for the day. Did people plan through the day appropriately? What we're going to start with tomorrow? And so that was really how the entire day was spent, kind of going from discussion to planning to discussion to execution to more discussion. And in many ways, for the entire month, 6 weeks that we really did this intensely, you had the same meeting schedule every day. same set of problems every day, and hoping to move the needle for our staff so that they would have what they need to care for these patients when they came, as they were discharged, as we were learning about the disease while we had the patients in front of us, right? This was a novel thing for us to treat, and we did not, we knew it was an infectious disease. We didn't know what the length of stay would be. We didn't know what the actual needs would be. We didn't have a real treatment other than supportive treatment at the beginning. And so we're learning and meeting and doing throughout the day. Was very different experience than multiple different types of projects, which most of us are used to. The single focus and cadence was a very unusual experience.
And I think as you look at this picture, this was what we would start going through around what are we going to be able to need to do? And literally each and every one of those lines, from how are we going to manage if we don't have enough resources and we can't care for patients? So crisis standards, do we have staff providing? How many patients are coming in? Is our ED overwhelmed? Do we have enough ICU space? Down to what's our strategy today around PPE? And have we got a boatload of N95s that have come in, or are we down to, 4 boxes, and how are we going to manage? So it literally went from the highest level of what is today's infectious disease recommendations for our care of the patient, or how we're going to cohort patients, or what care strategies and infection control strategies or PPE used to be doing, to is the staff able to get enough food and water? And unfortunately, when we have patients who are dying, how are we handling that? So it was, you've never experienced the breadth and depth of needing to make these decisions across the organization at all levels, every day, all day long. If you go to the next slide, I think this kind of gives you a picture. Literally, as we were doing the same kind of planning and strategizing, we were managing data. And some of this was specifically around COVID patients, COVID risk patients, or persons under investigation, how many regular patients were in the house, and where might there be space as those numbers continued to escalate. At that time, we didn't know. We were getting models of patients across the organization, and the line just kept going up to infinity. We had no idea what the trajectory of this would be and when or what would be our peak. So we were literally paying attention to rooms, spaces, critical care areas, ventilators, and across the system on whether we could actually accommodate patients. And then what kind of care models could we provide if we didn't have clinical staff resources to do so? I think the rest of the slides kind of give you some pictures around our communications, which was immensely important across all of the systems. And then I think the rest of the slides, we certainly can share at another time, but they really went through response plans and strengths and strategies. But I don't want to take up all of our time to talk about the structure and the model. It's really educative, but I don't know that it says the richness of what we wanted to talk about.
Great, thank you. Eddie, you can take the slides down. I thank you for sharing that, because I think it highlights, the complexity of the work that you were doing. And I want to focus on, just for a minute or two, the communication piece. I think that one of the things that was frustrating for all of us as clinicians was that the guidance from the CDC and other organizations seemed to be rapidly evolving. How, as an organization, did you work to streamline and manage communication? Because it seemed like the volume of emails that we were getting about COVID was overwhelming, and I couldn't keep up with, what we were supposed to be doing today, because it seemed to be different from what we were doing a week ago. How do you think that we did, and how did you as a team work on managing communication?
Peggy, you want to start?
I'm going to say, I think we did the best I think we did the best we could. It was a really hard problem. And we were changing the rules every day based on a series of parameters, including supplies, right? So the basics were, did we have enough to really give supplies to our staff, and in what environments were we going to use those precious supplies that were absolutely required for patients who were having an aerosol generating procedure and they were COVID positive. And so backing away from that, as we got more stable supplies, as we got more capable with our ability to distribute, we could then liberalize some of the use. But in that liberalization, that created some of the confusion. And so I think we were balancing a lot of things at once. And if you look at the infection prevention guidelines, they're incredibly complex. What our staff needed was simple. And so it was hard to interpret, how do I take this very complex set of rules and bring it to the staff and make simple actions for them? We did a lot of that. I would say we did a lot of that, like I will call it hand to hand. We walked the floors and units and talked to our staff to see what they understood, what was making them uncomfortable, how they were doing with their supplies, and really trying to understand from the front line what was working and what wasn't. I think we're really lucky here at this site with our clinical leaders being very engaged. And so we had great help in our chief level, really seeing their staff, spending time with the staff. And so for an example, Scott Chisel, our chief of medicine, was really up on the units every day. Corey or myself or Lynn Morrison were really up on the units every day talking to the staff. And that was one way we were understanding where they were at. Did a lot of weekly webinars. The emails were difficult. I think that people found this very challenging, but having Roger Clark, our infection preventionist, speak to what he believed was the best practice, someone who's very credible to the staff, those were the things that were impactful. I think much more so than the daily broadcast, but more the people who are trusted, having the data, talking to the staff directly really did help bring some credibility. And I will say the first few weeks, the credibility was challenging, and understandably. It was a very challenging time to better understand what we really needed to do and what we could distribute to people fairly. I would, not sure we could do it better, but it was definitely hard. I understand staff's frustration for sure.
And I think probably one of the advantages that Brigham and Women's Faulkner has as compared to the main campus is our size. I mean, it's relatively easy to see and run into and interact and ask direct questions of people who are in leadership positions like you and Corey. You mentioned Scott Chisel, who's chief of medicine, Roger Clark, who's one of the infectious disease doctors whom I have probably called, countless numbers of times with questions, and he's always willing to answer them. And so I think that's probably one advantage that a smaller institution has over a large one, is that it's relatively easy to find people and ask them questions directly.
Absolutely.
So in your travels talking to staff, I want to shift gears for a minute and talk about a buzzword that we've probably all gotten sick of hearing, but it has become so resonant over the last 6 months, and that's wellness. How did you monitor stress levels and wellness amongst the employees, particularly as Chief Nursing Officer Corey, amongst nurses? And then I'll ask Peggy about physicians and other clinicians. What were you hearing? What were you seeing? How were you trying to monitor that?
So as Peggy said, I do think we certainly had nurse leaders at every entity in every area. And because we had closed down so much of our services around our ambulatory and our surgical services, we actually had additional nurse leaders that were sharing some of that touch points with staff. But it really was having rounding 24 hours a day, 7 days a week, to touch base with staff to ensure that they were, to squelch fears, to clarify confusion, rumors, conjecture, to ensure that people were feeling as cared for as they could be. And there was a lot of fear around, is this the right PPE? Are you sure I am going to be safe? And it really was answering those. This is the best information we have. It's based off of infection control guidelines. We will get sufficient supplies in. We are sure, or we're rationing some of our supplies because we want to be sure we have it for the long haul. But it really was touch points. I rounded 7 days a week, and certainly it was, as incident commander, important that people see and feel comfortable to say to me, are you sure, or what's going on? And I would literally ask, do you have everything you need? What are you worried about? And I think staff were really open. That's one beauty, as you said, about the Brigham and Women's Faulkner, is that we're small enough and there's space validity with a lot of our caregivers and a lot of our clinicians and our leadership team. So people really felt that they had human connections.
Thank you. Peggy, what about you in your daily talks with physicians and other clinicians? We have nurse practitioners and physician's assistants as well. What were you hearing, and how were you monitoring the stress level and wellness of your clinicians?
So we definitely could, I think a couple of things. The redeployed staff was actually one of the most helpful pieces, because what we did do is try to relieve some of the work, the administrative burden, with staff who were not working in their usual areas. So we had, and I will say by volunteer, almost exclusively, a lot of our APPs, our nurse practitioners and PAs, volunteered to work in areas they didn't usually work in to support the work. So often they would, all of our orthopedic NPs and PAs were redeployed to our ICU, and they did a lot of documenting there, and they did a lot of communication to families. They're not critical care experts, but they could take the burden away from the providers who were up there trying to do the pieces of work they had to do. Our anesthesia group took on a task of intubating and putting in all the lines in the house. They're not usually have that task. They don't do the central lines for us. And so they made a system and a schedule, and because they were available, not doing so many cases in the OR, they actually were deployed to the ICU or to the floors and doing all those procedures. Again, time work that takes a lot of time for a lot of our staff, and they just took it off their hands. And I've been told a number of times they offered to do additional work as well as they were there. So we've been really impressed with everyone's ability to pitch in. I think that together, the fact that the teams came together was a huge help for the morale, and they did that honestly for themselves. Like, we helped bringing people in, but this was a volunteer army in many ways. People were very willing to help and to step up. But we also used our psych and social work services to be directly engaged with the staff. That group initially set up group meetings via Zoom to try to make sure staff had access. And what we found was that people were not taking them up on that offer. There just weren't a lot of attendees, yet we knew the staff were very anxious and stressed. And so we asked for a change in their structure. It made sense initially for them to think about a virtual approach, since we were doing a lot of our psych work virtually, but it wasn't hitting our staff. And so they took the charge when they saw that it wasn't working, and they went with a lot of our nurse leaders, or they made rounds with the teams, and they offered, and they checked in after someone had a significant number, like the units had many more deaths than they were used to. And so they really were checking in on those units that had either a high incidence of deaths over the last few days, or knew someone who had a challenging death and didn't have a family member, the things that were really hard. And so they were deployed in those ways, and they actually changed their plan when they saw it wasn't really supporting the staff in the way that they had initially intended. Nevertheless, it's hard for the staff.
I know
that we offered, still hard.
Yeah, I know that many of the frontline clinicians are hospitalists who tend to be on the younger side and have young families. And similarly with nurses, many of our nurses are young with young families. And I've heard anecdotally that some socially or physically separate themselves from their families for extended periods of time while they were covering the hospital. Talk a little bit about that. What were you hearing? Were people doing that, and how was that contributing to some of the stress and anxiety that people were feeling?
So certainly we heard that and heard a lot of staff who were worried about, remember, transmissibility was unclear for quite a long period of time on what was the vector for transmission, and can I carry it home? We were asymptomatic, and how long would I be asymptomatic? And the quarantining for how many days was changing rapidly. And so what we actually had the great luxury is MGB offered hoteling for staff. And people could choose, if they did not have a place that they felt comfortable going home with families, that they could actually go to a hotel and it would be paid for. So that some people did actually take up on that. But I did hear regularly of staff who were, undressing in the garage and not coming into their home and not going until they had showered and would stay away. I know many persons, including myself, were not going near elderly family members and were, not able to speak to elderly family members or small children and grandchildren. It really was isolating for all of our healthcare employees. And I think we've gotten better with that, but that was an enormous strain on our frontline workers.
Great, thank you. I want to segue to talk about your own personal stories and your own personal journeys, because I can only imagine as leaders that this had to have take a personal toll as well, because I was there some Sundays, Saturdays and Sundays, and I think there wasn't a Saturday or Sunday when I was on call that I didn't see one or both of you roaming the fourth floor. And so I want to know first, did you get any days off, or did you work, were you on call? Was your beeper always on, your cell phone always on? And if so, how did you take care of yourselves? Corey, why don't you start with that one?
So this was perhaps the hardest thing that I have ever done in all of my career. As the incident commander and stepping into that, it was an enormous responsibility. And not something I have not experienced before, but not to the depth and breadth of this or the length of time. So yes, personally, I was in the hospital for 2.5 months straight without a day off. And I would work 12 hours a day. And I know going to sleep at midnight, reading emails to make sure I had answered the most recent piece, and up before 5 o'clock to make sure I now knew when was prepared for the next meeting. So it took an enormous personal toll. And, you come into this thinking, all right, we'll get through it. It was the fact that it was day after day, week after week, and then into months, that I think we underestimated how long of a time we would need to stay in this structure.
So how did you manage then to, because I can only imagine that, if I had to work 2.5 months without a day off, especially the kind of hours that you're working, what were your strategies for self-care? Did you have any specific strategies that you want to share with us?
Well, fortunately, I think sleep is way overrated, so that worked well for me. And I have to honestly say, and Peggy was my partner, and I think it really was looking to our team. And that incident command was an amazing group. And I think we often supported each other. There were days and decisions where any one of us personally felt a burden or was overwhelmed with decisions that needed to be made. And it was the ability to turn to our partners and our friends and peers in this group to say, I need help. And I think we often gave, it's like, you need to go home. And don't answer your phone. I'll take care of it for you. And it was that kind of being attentive to each other because all of us were doing those kind of hours and needs. And it really was supporting each other through that. I think that's what helped me the most from a personal care perspective.
Thank you. Peggy, what was your experience?
So I like sleep, but I may say personal care is overrated. It's a problem I have. But I would say it would have been hard not to be at the hospital for an event like this. So I think those of us who were in the incident command structure in retrospect actually feel very lucky despite the work, because it's hard to, and we've heard about this from some of our colleagues who weren't actually in the incident command structure. If you weren't in it, it was very isolating as well. So none of this was easy. I think the lucky thing for, and I think it's personal for me and Corey, we were lucky never to have the same bad day. And so we constantly were supporting each other through, I'm really worried about this. I'm not sure I'm making the right decision here, versus I'm not sure I'm making the right, having the right interaction across a different entity. I need to work with another partner and I want to make sure I get this right. Versus to the point of occasionally really even being, needing to go in my office and shut the door. Those are long, hard hours, and maintaining your composure was critical, but it wasn't always easy. And so there were times when we both really leaned on each other. And it's probably the biggest part of our self-care was having that partner and really being able to say whatever we needed to say to support each other through it, and then be able to move the rest of the team forward. And I do think it would have been very hard to get through without the other. And it's brought us as a senior leadership team to closer and closer together. But certainly for Corey and I, our relationship has grown enormously as we counted on each other, and in very specific ways through it all, right? I mean, we just both knew whatever levers we needed from each other, we had them in very specific ways. We counted on each other. Yeah.
And how did your families react to this, to the, what you were going through and the hours that you were working? How did they react?
So my family has always known, despite having children, et cetera, that work comes first. And that's part of where I come from, in that my role has always been in a leadership role, and hospitals don't close down no matter what's going on. So, and I have the luxury of having grown family. I don't have small children any longer. So there wasn't that burden and pressure on me that I was taking something away from small children. And I don't take that lightly. Other people could not make those decisions that had to support dependent family members. So my family was more than supportive of me and had no additional burdens or expectations. But I'm in a very novel place that I didn't take that away from a small family or elderly parents that depended on me. So it was good. It was very good.
Peggy, your thoughts?
Yeah. So yeah, I'm lucky as well in that my husband's always been the person at home. I've always been the person that works the long hours, so that didn't change very much. My kids are grown, also college age. They were home, which created a whole different set of stress in my house, having 3 college age children who should be at college, living in your house, trying to do online learning, and also not wanting to do online learning. And my husband really did deal with all of the angst at home and the struggle at home, but it was real. They were, I did have one of my sons, when he came home, I was sincerely worried about him. I thought we were going to need to get him some help. And then he just kind of moved along, figured out how to deal with the pandemic and isolation. He's a very social kid, and that was a little bit of a worry while I was here, but mostly he's always done that work. I've always had long hours. This was just unusual, but my children were incredibly thoughtful around it. I mean, I have to say they were respectful and understood the purpose. And I really saw a part of them that you don't normally see as a parent, which was something I'll always carry.
Thank you. I want to move to a slightly different topic. One of the things I've become interested in over the past couple of years, especially now that I'm teaching in a master's program, is learning about leadership and leadership styles. And you're both women who have major leadership roles within the institution. Are the leadership styles you think of women leaders different from those of men? And did you encounter in this situation or any situation difficulties as leaders, do you think, because of your gender?
Go ahead, Peggy. I'll let you get started.
Okay. So I'm actually going to say I don't think women have different leadership styles. I think the reaction to women lead different. So then when a woman leader is in the room or present, that people around them may react very differently. That may cause some different behaviors, but I think you see the same variety of leadership in women that you do in men. It's just the environment around them may be very different. And I've thought about this a lot, especially as a surgeon, as a trained surgeon. You do have to have a specific leadership style to have trained when I was a surgeon, as I'm not the youngest surgeon in the group. And it is, I do see the variety. The expectations of women leaders are very different, though, and the ability to get along, the ability to collaborate is an expectation that is, I think, quite different for women. It's a good finding in all leaders, but I think the expectation is there in women in a different way. And so I certainly have in my career felt a fair amount of challenges around being a woman and being a leader, but never any that weren't insurmountable, and never any that I couldn't have a voice around. Just different behaviors, I think, and you have to think differently about how you approach things. Corey, I don't know your thoughts.
And I was just going to say, as a surgeon, when at least when I was in training, surgery seemed to be the most macho of the specialties, and
that's exactly right.
And so I think probably had to have some kind of toughness, thick skin to get through a surgery residency. It may be somewhat different now, but I think historically that was probably the case.
Yeah, I'm hoping it's different now, right?
And I think both Peggy and I have lived through when things perhaps were not necessarily as leveled playing field. I do feel now, certainly a woman in nursing is actually the majority. So we're very used to nurse leaders. And I would say in a opposite realm, male leaders in the nursing profession, our male nurse leaders, may actually find it somewhat more challenging because they are in a mostly female profession. So we kind of flip that. But one definite thing I sensed, and since I started here, is women leaders across this healthcare environment are extremely strong. I mean, you think of where our top CEO is a woman, and the majority of our leadership team at the Faulkner is actually women. So I don't sense that kind of challenges here, and have always felt it's extremely well respected. But I do think, and I will definitely support Peggy, and you need to constantly think of how your message is being received and what messages you are giving. I do think that is something, and not being a man, I can't speak to whether you think about it as often and as consciously, but I know we definitely is my message being received, and am I portraying the message that I want, and how is my audience taking it? So that's a constant tape that plays in a woman leader's head.
Well, thank you. As leaders, what do you think are the major lessons that you have taken out of this crisis, this pandemic, and how do you think it will help you to prepare for the next big challenge, the next disaster, the next pandemic? Corey, why don't you start with that?
So I do believe the being transparent and being an available humanistic leader was the most important. My standing with staffs, and I think even during this pandemic, one of the hardest days is when I had to face a group of staff who wanted PPE, and I had to tell them that I was very sorry. I had to restrict their access. Not that I believe they were in harm's way, but this was the standard, and we had to protect PPE for the long haul. So we can't just give it out and give it to everybody at all levels. It had to be restricted. And I left there with tears in my eyes, that I looked at faces of my staff who were frightened. And I really think understanding it made a difference that staff knew I was willing to walk the floors and be in their environment, that I heard and listened to what they were worried about and concerned, and I could see the conditions that they were caring for, their patients. And, I didn't go home and interact with families, because I literally, even as the hospital leader, was on the front line with the patients. So I do think being open, available, but honest with the staff was a message that very strongly stood me for the best, and it will be something I will continue to use as my structure.
Thank you. Peggy, what about you? What do you think are the lessons that you want to take out of this in preparing for the next big challenge?
So I was so impressed at what we could achieve. And when we had a single goal and a single mission, we had the staff to get that job done. And I really believe that this ability to trust people, to bring their best, to take a question and give you an accurate and thoughtful and careful answer, to move, like, we changed all the pressure gradients in the hospital. That was really hard work. And when facilities said we couldn't, I had complete faith that they had done everything they could. So really learning that the capacity people have to do the work that they're asked to do. I was so impressed with our staff coming back, particularly our leadership staff, every day to a new set of questions. We would sometimes change everything we asked for the day before and just say, yeah, that's what we wanted yesterday, but today we need this. And people would take a deep breath and walk away and set about solving that task. And I'm so impressed with the ability to bring a problem, break it down, ask for people's help and action, take that feedback and keep working that cycle. It was impressive to be able to solve a big problem or a small problem in that way. I just have taken away so much gratitude that we are able to work together as a team, but also the capacity of our staff to do what needs to be done, and above their pay grade frequently. Really, people really came together.
So in the last few minutes, I want to turn to talk about two topics that have been in the lay press. And the first is about what's happening with healthcare workers across the country in terms of compensation. So usually you go through a crisis, people work extraordinarily hard, and they get more compensation or bonuses. But we know with what's happening in healthcare that across the country, healthcare workers are facing reductions in compensation after a period where they've really put their all in. So tell us, what do you think you have to do to maintain morale in that kind of environment? Peggy, why don't you start?
So I feel like, yes, this is a huge challenge we're facing, right? Asking our staff to take risk, to work harder, and to receive either the same compensation or less compensation. It is definitely a challenge. But the difference between this and many other events is the fact that this event is impacting everyone. And so our staff also are aware of the impacts in other industries. And we've talked a lot about that. We are committed to keeping our staff working, to keeping our staff as whole as we can. And we worked hard through the pandemic to support people who didn't have work to do, who were at home and not working, but were on staff. We really worked hard to keep that level set as long as we could. I think our staff is aware of the crisis that the world is facing. And as long as we keep those communication channels open, that we're transparent, and that we are here to hear their concerns, most people appreciate the fact that we've been very, as an organization, Mass General Brigham has been incredible at really supporting people through the pandemic, but also that we've been fairly transparent about what we're facing as an organization. And I think leadership made some very good decisions around our own role in that and those reductions, right? I mean, that's really one of the most important things, is preserving our staff who make the least, and also the staff who make the most, to be managing those losses. So I feel like there's real credibility despite some of the challenges there.
Thank you. Corey?
No, I think what Peggy said is very true. This is not just a healthcare crisis with the pandemic. It's been a financial crisis for the world and for the entire country. And I think our staff really understand that we're in this to sustain healthcare for the long haul. And businesses have closed when they financially could not sustain their bottom line. We need to sustain our healthcare systems, and whatever it takes to do that, to be able to provide care for patients for years coming forward. And closing hospitals is not anything we could even entertain, knowing we were crunched for beds and worried whether we had those resources. I think our staff actually understand that. And as Peggy said, much has been put in to try to sustain people and keep them whole, particularly those employees who are the least fortunate with the most challenges financially. And many of our employees may now be sole breadwinners, but they understand the long picture, and that this is a burden that we're going to face for years, and we want to continue to provide care for our patients.
Great, thank you. And finally, one of the other topics that's been in the lay press and in the medical press a lot is about the disparities that became apparent because of the COVID-19 pandemic. And there was an article in the Boston Globe just this week that highlighted the story of a Faulkner employee and that employee's death from COVID-19, which brought to leadership's attention to the fact that COVID-19 was disproportionately affecting different communities, and certain types of workers within the healthcare environment were at high risk because of where they live in the community. So, Corey, can you speak to that a little bit and tell us a little bit about that story and what the institution's response was when you realized that there were these disparities and who was being affected?
I think, we actually did not expect the outcome. And we were very much tracking and trending employees who were becoming ill and expecting our employees would becoming ill. And we would do tracers for that. And we were tracking whom was impacted and where was the source for that. And it wasn't too long into that when we were looking at the tracer bodies. It was not our physicians and our nurses who were becoming ill. It was our frontline workers who were in the assistive personnel areas. And it was somewhat of an aha moment, is why on our campus, it was our food service workers who were becoming ill. And we really needed to look back and say, what was the commonalities to the food service workers? And it definitely was reflecting what was with our populations of patients. They were persons living in multicultural environments in our lower socioeconomic communities that surrounded the hospitals, and persons who were needing to work two jobs and therefore were getting exposed not necessarily always at the hospital but other places. And I think that was a little surprising for us, but as we saw it, we definitely made some changes in how we were going to support those persons and care for them. And I know as we talked about this, Peggy, you certainly had a lot to share, so I'll let you take over on our response to that identification of the groups that were being impacted with this disease.
Yeah, so I think one of the things we recognized is we hadn't thought outside of the four walls of the hospital. We really were focusing on keeping people safe while they were here, not transmitting the disease while we were here, with good hand hygiene, mask wearing. But I hadn't really thought about our employees that travel together, that work together in other facilities where they may not be getting the same types of support, or living in communities where they may not have what they need. And so we've done a lot of work and did a lot of work at that time with our staff here at the Faulkner and at the Brigham, where it was similar role types that were having higher incidence. And so we did educational programs for them at work, sent home a collection of masks, some more Purell, and then it did that in multiple languages for our staff members as well, so that they could bring home information to family members too, and really propagate this information to limit the transmission. So it was it certainly was, as Corey describes, an aha moment of thinking about our staff on their way to and from work, thinking about our staff when they're not at work, and what are the things they need from us to be safe and healthy. So I feel like we've learned a lot in that space, and we'll continue to leverage that in the future. And it's a challenging lesson to learn, but it's an important one to focus on.
Thank you so much. So I think since we're approaching the 2 p.m. hour, we'll close out here. But I want to first say thank you to both of you for taking time out of your busy schedules to help educate our community of learners. One of the reasons I wanted to do this webinar with you and interview you is that I have tremendous respect for you as leaders. So thank you for your service and your leadership. It was gratifying to see what tremendous leadership we had at our institution, and we thank you for your service. And I hope that you're now finally getting to have a little bit of time off as we've moved out of the pandemic. Thank you for sharing your insights on leadership. I think that there are lots of lessons that we can learn from that. As a closing reminder, attendees may gain continuing education credits for participating in today's session. To do so, please click on the link in the description below this video window to complete the evaluation and obtain the credits. This information will also be distributed through a separate email to today's participants. Along with links to a recorded version of today's discussion and credit information, the email will also include additional HMS COVID-19 resources. Please distribute to colleagues that you feel would benefit from this information. I invite our community of learners to join us for this webinar series on COVID-19, which will continue, as well as a new series that I'm leading on healthcare disparities and the effects of race and racism on healthcare and healthcare outcomes. Again, thank you to our panelists and thank you to our learners for joining us today.
Thank you, Kevin. It's been a pleasure.
Thank you.